Good evening to everyone. My name is Dr. Faizal, an endocrine surgeon based in Chennai. Before I start, I'd like to thank Professor Sabratnam for the opportunity. The topic right now is TSH Assays. Okay, it's quite a difficult topic in the sense that a lot of biochemistry is involved, so I try to make it simple and concise. So it's quite a short presentation, but I hope it's useful. The first thing is, before you start on TSH assays, you have to understand that based on the history, right, it was discovered in 1916 as a thyrotrophic substance from a pituitary extract by Smith and Allen. And it was only in 1979 that we were able to isolate the TSH structure. And this is important because now we know that it's a glycoprotein. It consists of two subunits, an alpha and a beta subunit. The thing about this alpha and beta subunit is that the alpha subunit is common to TSH, HCG, LH, and FSH hormones. So this is what really makes it difficult for us to measure the TSH levels in the initial years. But right now we have so much of sensitive assays that can enable us to measure it to the correct level. And then we have the beta subunit, which was unique to the TSH. We know that the beta subunit is the one that confers the biologic. It binds to a TSH receptor, and also it has an immunologic activity because now we can use the antibodies in the TSH assays to bind to this beta subunit, which is specific to the TSH thyroid stimulating hormone. So we're able to measure TSH alone and not also HCG and LH and FSH. So that's why this structure of TSH is very important. So before we go on to TSH assays, just to have an idea of TSH function is that TSH actually stimulates the growth of the thyroid gland. It regulates the synthesis and the secretion of thyroid hormones. So we want to know the level of TSH because we need to suppress TSH. In certain cases, we give a suppressive dose. So we need to suppress TSH so that we do not have any thyroid tissue growing after post-thyroidectomy for a cancer patient. So that's why it's important for us to know the level of TSH. And also by knowing the level of TSH, we know that a patient can be clinically diagnosed as hypo, hyper, and then based on that, we give thyroid hormones. So we know now TSH also regulates the synthesis secretion. So by giving thyroid hormones, we're actually we're giving a replacement therapy and then suppressing the TSH back to its normal level. So this is important in this way to have an accurate measurement of the TSH. Now, before we measure TSH, there's some physiological variations we should know. One is that it can have various levels. Serum TSH levels can vary from person to person and within individuals. The thing is that it has a pulsatile and follows a circadian rhythm within the same patient, that it peaks between 11 p.m. and 5 a.m. So you're not going to send a blood sample in the middle of the night. So the peak secretion that happens at around midnight till early morning is something that can be avoided. And it reaches a low level between evening 5 p.m. till night 8 p.m. So those times we don't even send blood samples, so we are not worried about it. But this is just an idea of how the TSH actually can vary within an individual. And this pulsatile level actually is absent in hypothyroid. So you can probably say hypothyroid patient, I can send a blood sample anytime. It's not the case because we need an accurate measurement. That's why we send in the fasting level in the morning. Now, the magnitude of change that we are talking about, this pulsatile secretion that brings about this change in the TSH level within an individual is actually, it doesn't go beyond the upper limit or beyond the lower limit. It is within the normal TSH reference level of the population. So we don't have to worry much about this variation. It's just to give you a background check on what the TSH level could be if you have taken it, or if a patient comes at this time, a blood sample has been taken. Now, the TSH has a plasma half-life of 30 to 60 minutes. It doesn't have a short half-life like a thyroid hormone or any other norepinephrine or epinephrine. So we know that it can stay at the plasma level for at least 60 minutes before it reduces its half-life. Now, it's not affected by any carrier proteins because it's not transported by any carrier proteins. So unlike thyroid hormones, which depend on thyroid binding globulins, so it's not affected by these thyroid binding globulins. But there are other factors that can influence TSH secretion. So these factors are something that you should consider when you have elevation or decreased TSH. But these are the normal factors that we know in our clinical setup. We know that in primary hypothyroidism, subclinical hypothyroidism, TSH is elevated. We know that if the patient does not have adequate thyroid hormone replacement, TSH gets elevated. There are certain medications that we should actually look up dopamine antagonists in the history. If you find that the patient was on metoclopramide, domperidone, domstar, so all this can have an effect on the TSH levels. Lithium, iodine-containing drugs like amiodarone, iodine-containing compounds, interferon. So all this can cause an elevation in TSH, and TSH secreting neoplasms on the pituitary, and cortisol, glucocorticoid insufficiency. All this can cause elevation in TSH levels. Now, the opposite is true when it comes to decreased TSH levels. So the table 3 will show you that it's hyperthyroidism. You know that the T4 levels are very high. The hyperactive gland will produce a lot of hormones. So the TSH, by negative feedback, it actually gets reduced. So a patient recovering from thyroid toxicosis can still have decreased TSH level because it takes at least 6 months, sometimes to recover. And suppressive therapy and the medications, if you have dopamine antagonists as a factor that causes TSH elevation, a dopamine agonist like bromocriptine, if you're giving for glycoria, it can cause a decreased TSH. And you have glucocorticoids, interferon, pregnancy, non-thyroidiness. So these are some factors which you should consider when you are looking at the TSH value, and you should probably consider in your history taking. So if you look at the history of TSH measurement, you'll find that the first measurement or the quantitative assay of TSH was first reported in Germany in 1932. Now, that actually was not replicated, and it did not come up in laboratory laboratories across the countries or across the nation. It was only in 1958 that McKenzie, he developed the electrophoresis method, which could actually have a sensitive TSH measurement. It was a bioassay of TSH. So this was actually replicated in laboratories and was adopted by many laboratories at that point of time. The problem was, as you know, electrophoresis, how it behaves is that you have electrical field across where the TSH has to move either to a positive or negative charge, depending on the ionic charge that it carries, and based on the weight of that TSH, it will move to a certain distance and stop. So there was no sensitivity in the sense that they could not differentiate between a very high TSH or a thyroid stimulating immunoglobulin. They did not have the facility to know whether this molecule that was moving across the electric field in electrophoresis was actually a TSH molecule or a TSI, a thyroid stimulating immunoglobulin. So every high TSH could be seen in hypothyroid as well as in Graves' disease at that point of time in 1958. However, in 1965, there was what you can say a really wonderful achievement, developmental milestone, where two physicians by the name of Dr. Burson and a biophysicist, Dr. Yellow, both of them had developed a new procedure called radioimmunoassay, and they used it to measure plasma insulin, and that led to a Nobel Prize for them in 1977. So if you look at the term radioimmunoassay, it's like you're using a radioisotope, you're having immuno, means you're using antibodies, you're using a combination of both to measure your TSH, which is the antigen. So this led to the breakthrough in the measurement of hormones as such. So in the same year, the first person or the first time a radioimmunoassay of human plasma thyrotrophin was actually measured by Robert Utiger. So he was the first person. If you ever have to look up a TSH value in the laboratory, you know that the first person who actually did it was this man. His publication was the one that came up in 1965. So we owe all the credit to him for the first radioimmunoassay of human TSH levels. And it was because of the radioimmunoassay procedure that was developed by the Nobel laureates in 1965. However, today's TSH assays are now categorized as first, second, and third generation assays. This is with reference to Nikolov and Spencer in 1990 publication. And this reference or this categorization between first, second, and third is based on a functional sensitivity. How sensitive are these assays or this measurement, how sensitive are these tests, the first, second, and third, in measuring the lowest concentration of TSH in the patient's blood. So that's how we actually categorize the first, second, and third. So the first is not that sensitive, and second becomes even more refined and sensitive to measure a very low level, and third even ultra sensitive. So the first generation TSH is TSH assays were introduced in 1965. They were used till 1985. These were actually radio immunoassays. Okay, so what happens is that we have an antigen that is the patient's TSH in the blood sample. We now mix it with the radio labeled TSH antigen. That is, we have a prepared antigen which is now TSH also, which is now labeled with the radioisotope, and we mix both with a limited amount of a TSH antibody, a TSH specific antibody. So we have two antigens and one antibody. So these two antigens are now going to compete for that one polyclonal antibody, and one radioisotope label which is attached to the TSH antigen is the one that's going to give you the measurement. So what happens is that there's a competition between the patient's TSH and the TSH which is labeled with the radioisotope for that antigen binding site on the base of the tube, which is the antibody which is placed there. So the competitive binding actually, if there is more TSH from the patient's side, this will displace and bind to more of the TSH antibodies, specific antibodies, leaving less of the radioisotope bound TSH, which will get washed away. And so you will have less isotope or less of the emission from the patient's blood test. So the problem with this was that it could not measure, there was no direct measurement of the patient's TSH. So we are actually measuring only the radioisotope that's being emitted from the TSH, which is labeled, which is actually added to the well or the test tube. Okay. So the lower limit of TSH which could be measured with this method is only up to 1 milli international units per liter. So radioisotope assay, the first generation, could not detect the lower limit of the euthyroid reference range, that is the 0.4. We know now that, I mean, the current TSH reference range is between 0.35 to 5, but the TSH first generation, which was present in 1965 till 1985, the lower limit was only 1. So we could not actually replicate what we have now that we are doing with the third generation TSH assays. So this was a disadvantage with the first generation. This diagram is a schematic which will show you how the antibody on the left side, the antigen and the radiolabeled antigen, that is a TSH antigen, which in the center is the patient's one. The radiolabel is one that's prepared outside, and all of them are mixed together, and finally you separate the free fraction, and the bound fraction is what is being measured. So the bound fraction, which is, if you have a lot of radioactivity coming from the sample, then you know that there is very less TSH from the patient side. So all the bound ones are from the TSH, which is radio-labeled antigen. So the measured signals is actually inversely proportional to the TSH in the sample. So we are not actually measuring the TSH as such from the patient's serum. So it was not that sensitive. So sensitivity was around 75%, specificity was of 90%. Because we're using a polyclonal antibody, right? An antibody which is not specific just for TSH, because it can bind to both the alpha, beta, and since the alpha subunit is present in other glycoproteins such as HCG, human gonadotropins, and luteinizing hormone, so there's a lot of cross reaction. So even these are retained within the antibody by antigen binding sites of the antibody. And the upper limit of normals, like we are measuring, was all the way up to 10 milli international units, and the lower limit was around 1 milli international units per liter. So the only clinical advantage that we had with the first generation was we can only detect an elevated TSH, that is, we can diagnose primary hypothyroidism only. There was no way that we could diagnose a hyperthyroidism because the lower limit was 1 and we could not measure the actual value of TSH from the patient side. Okay, and so it is not really used in nowadays, but till a certain time it was used in neonatal hypothyroidism, where you know the TSH should be very high and you can cut down the cost factor. So they were using it in certain centers for neonatal hypothyroidism. Then came the second generation TSH assays. These were introduced in the 1970s, and it is an immunometric method. What we use here is antibodies and antigen, but we're not labeling the radioisotope with the antigen, right? We are labeling the radioisotope with one of the antibodies. So we are now using two antibodies with one antigen. That one antigen is now the patient's TSH. So two different polyclonal antibodies, they will bind to two different sites of the antigen, the TSH. it may not be alpha, it may not be beta, it can bind to any site of the TSH antigen. Because they were polyclonal antibodies, they were not specific for TSH, they could bind to any site. And a radioisotope or an enzyme is used to label one of those antibodies. So you have an antibody at the base, which was already having an antigen binding site. So you pour the antigen, that is the TSH, and then you add an antibody which is labeled now with the radioisotope and enzyme. Then you measure the level of TSH using the autoanalyzer. So now we were able to have a much more higher sensitivity, in the sense that the lowest limit of TSH we could measure was now 0.1 to 0.2 milli international units per liter. So the sensitivity now increases up to 96%. The specificity is still 93% because we still have interference from other glycoproteins. So like I said, the disadvantage with second generation TSH assays is that you have polyclonal antibody production. You know that this comes, this is actually there in textbook of Panikkar microbiology. I think it's one of the pictures there, but color diagrams there. Actually, the polyclonal antibody is just injection of the antigen into the mouse, and then you find that you get an immune response, and the antibody is now separated from the serum, and you purify it and use it for your laboratory testing of the antigen TSH. So you're going to get cross interference from other glycoproteins which share the subunit of TSH, like HCG and FH and LSH, FSH and LH. So apart from that, you also have heterophil antibodies. These are actually antibodies which are formed against the mice gamma globulins, and these antibodies can be present in some patients. So the antibodies which are used in the TSH assay, they are derived from the mouse. They cross-react with the heterophil antibodies in the patient, that is antibodies against these mice gamma globulins, and they again result in very high TSH values. So this is the disadvantage of second generation by using polyclonal antibodies which are non-specific for TSH. Then came the third generation TSH assays. So what happened now was that there was a revolution where Kohler and Milstein, they developed a new technique in 1975, a hybridoma technique, where they could develop a method of producing large scale monoclonal antibodies. So they injected the same way they injected the antigen into the mice, and then harvested the cells, the B cell producing cells from the spleen, and then they mixed it with cancerous cells, the myeloma cells of the plasma B cells from the multiple myeloma patients, and then they used and they cultured it, and culture from the hybrid cells, and these hybrid cells were grown in the culture. So you had the hormone, the antibody producing cells from the spleen, and the fast growing tumor cells of the multiple myeloma patients. So both these factors help in producing a new cell which was actually growing fast or dividing fast, and also producing more of these hormones or antibodies against the hormone. So this was the hybridoma technique, and because of this we were able to actually produce on a large scale monoclonal antibodies which are now specific for TSH alone. So we can now develop antibodies, highly specific monoclonal antibodies against an alpha unit, a beta subunit. So eliminating the interference that we have from other glycoproteins which share this alpha subunit. So this is basically the schematic diagram of how the immunometric assay of second generation, third generation, how they actually made was the solid support at the base of the tube or the well that they use, and then on that there is the TSH monoclonal antibody. Now if you look below, the diagram will show the beta subunit of the antibody of the antigen binding to the anti-beta antibody on the solid phase material. So all the beta subunit, that is only the TSH gets bind to the base of that antibody, and finally you have an antibody that is another monoclonal antibody now binding to the alpha subunit, and that is also labeled to either an enzyme, a chemiluminescent reagent, or a fluorophore reagent. So this helps in being more sensitive in detecting TSH alone and eliminating the interference that we get from HCGs and luteinizing hormones and follicle stimulating hormones, which share the subunits, the alpha subunits with TSH. So we had highly specific monoclonal antibodies. We now have highly sensitive labels, new enzymes, fluorescence signals, or non-isotopic, that is non-radioisotopic. They are no longer emitting radiation. So chemiluminescence signals we can use, reagents we can use, and now we have a sensitivity that can measure up to 0.01 to 0.02 milli-international units per liter. So this is significant now. Now we can classify patients or categorize them into really overt or really severe hyperthyroidism. Now we can diagnose hyperthyroidism with much more accuracy and much more confidence. So the low concentration of TSH we can measure now with third generation TSH assays, and this is sensitive up to 97%, but the specificity is still 93%. Still there are limitations. We will come to that, and the results will come in minutes. So if you were to compare the functional sensitivity of first generation, second generation, and third, fourth generation, there's also fourth generation. So each generation actually differs tenfold in its functional sensitivity. So the lower limit of the first generation was only up to 1, the next second was up to 0.1, and the third was up to 0.01. Now the fourth generation came, and it was actually by a company called Olympus, and they had a machine that was able to measure or eliminate the interference that came from HCGs and FH, follicle stimulating hormones and luteinizing hormones, thereby actually increasing the oscillation in that machine. So eliminating that interference and measuring even the smallest quantity of TSH that's actually present in the patient's blood. And they said that they can reproduce this value 0.001 across with the same machine. So, but I don't think it has actually picked up in other laboratories. So most of the thyroid testing at present is currently done using automated analysis with third generation immunoassays. So in third generation, we are using antibodies which sandwich the antigen TSH, and we don't have to use radioisotope now. We use enzymes or even chemical reagents which emit fluorescence. So how did this affect our TSH values over the years? So if you look at the evolution of first, second, and third generation TSH assays, you now can have an idea that the TSH reference range has changed over the past 3 decades. Right, from a lower limit of 1, we can now say we can measure 0.35, we can measure 0.1 or 0.2 based on the population, or based on whether the patient is actually pregnant or not. So that there's a difference in the values of TSH in different population categories. So the reason why this TFTs or this TSH assays has become important is that we have now changed from a thyroxine-based strategy to a TSH-based strategy. So now that we are now treating post-thyroidectomy patients who are malignant patients, we have to put them on suppressive therapy. Now the TSH value is very important for us. We need to categorize them to low risk, high risk, intermediate risk. So this TSH value is now quite important, and having a sensitive TSH assay is significant for us. And again, like I said, trimester specific pregnancy TSH levels. So the first trimester, you know that lower limit has to be 0.1, 0.2 in the second, and 0.3 in the third trimester. And by actually measuring the TSH levels below the lower limit, so we actually know that we can have a reduced TSH between 0.1 to 0.4. A subclinical hyperthyroidism can be categorized between 0.01 to 0.1. And a profoundly suppressed TSH when it's less than 0.01. So this can help us to adjust thyroxine suppressive therapy based on these values. And these values can only be obtained if you're using a third generation ultra-sensitive TSH. So like I said, the TSH reference range has changed over the decades. Initially, when we're using the first generation radioimmunoassays, that is during the period 1970s to 85, the lower limit was around 1, the TSH, and the upper limit was all the way up to 10. And once the second generation came into work in 1985. Around that period, we had almost what we're having now, a 0.3 to 5. So till then, as we try to increase the sensitivity by using monoclonal antibodies, so the third generation TSH assays help us to now bring the TSH reference range between 0.3 to and 4 or 4 to 5. So the guidelines now has this reference range within in the literature, and that's what is being utilized across the globe. So because we have a new current TSH reference range, that 0.4 to 4.0 within the guidelines, now we know where we can categorize subclinical hyper, subclinical hypo, or overt or clinical hypo and clinical hyper. Now we can categorize these patients within that reference or within that TSH values based on the TSH values, because now we have a good reference range, and this good reference range was enabled by us because of the TSH assay, the third generation TSH assay. And so we have a publication of guidelines now that says that the current TSH reference range is between 0.4 to 4. So how did we get to this reference range was based on the largest study in 2002 by the National Health and Nutrition survey, which was done in the US. It was a US study, 16,000 subjects. They used the third generation chemiluminescence assay. So 95% within the two standard deviation had a TSH between 0.45 to 4.1. Now this was the normal range. So, but the lower limit of normal that they could obtain within the population was even up to 0.3, which they thought was normal. And the upper limit was even up to from 2.1 to 7.5. Why this variation is because the TSH levels can vary with age. It can be high in the elderlies. It can be higher in whites, that's ethnicity matters, iodine intake, BMI, smoking status, pregnancy, autoimmune status, all this within the general population can have an impact on your TSH, which can actually be normal for that population or for that category of population. So the most of the labs that we know we come across in our place or anywhere across the globe, the labs will have 0.35 to 5.5 milli international units per liter. And the guidelines by the American Association of Clinical Endocrinologists says that it's between 0.4 to 4. And all this has been possible because of the third generation TSH assays. Now, despite having a very good sensitive TSH assay and despite having an established reference range, there are still limitations in this third generation TSH assays, or for that matter, because there is still cross-reactivity interference from HCG, from LH, and also TSH isoforms. These are actually inactive TSH forms, which can be seen in central hypothyroidism and TSH secreting pituitary tumors. And this interference is what is being tackled in fourth generation TSH assays by actually having the autoanalyzer calibrating its speed and trying to eliminate and washing it out from the sample. So heterophilic interferences, like I said, anyone who has antibodies against the immunoglobulins from the mouse, so human anti-mouse antibodies, that can also cause a falsely elevated TSH. And interferences, like I said, drugs, which I showed you in the early slide, they can also have an impact on your TSH assay. So hospitalized patients when they're receiving multiple medications, non-thyroidal illness, biotin, for example, it can also cause elevation on the TSH. So you actually have to stop it 2 days before the TFT. And finally, patient on a rare occasion can have antibodies or autoantibodies against TSH itself. So an endogenous antibody within his own having against TSH, which is quite rare. Now, having been able to accurately measure TSH with a very sensitive third generation TSH assay, now we know that the TSH is quite sensitive to the changes in FT4. There is a log linear relationship between the FT4 and TSH. So the TSH, actually there's 100 times change for every 2 times change in your FT4. So TSH is actually quite a very, very, very sensitive test for the diagnosis of both subclinical and overt hypothyroidism as well as hyperthyroidism. And this is only because that we were able to have a good reference range using the third generation assays. So to conclude, third generation TSH assays are the current standard of care, and TSH assays have us now so sensitive for detecting the different degrees of TSH suppression. So we're able to adjust the thyroxine suppressive therapy based on that and have the patients on follow-up because of that. And a sensitive TSH assay is actually very much essential for an accurate clinical diagnosis, for adjusting the dosage and monitoring the response. And TSH being more sensitive than FT4 in detecting thyroid dysfunction. And you need to have a very sensitive TSH assay, which will enable us to actually categorize this patient based on the TSH values. So to actually summarize, you just have to remember the first generation TSH assay. You know, you have two antigens, and we are not actually measuring directly the TSH antigen of the patient, and we have only one antibody. Second and third, we are actually using two antibodies, but in second, we are using polyclonal antibodies. However, in third generation, we are using monoclonal antibodies, and that is more specific, and it eliminates cross interference from others. And to eliminate even that cross interference further and trying to measure even the smallest quantity of TSH is what fourth generation TSH assays are trying to improvise. So these were the books that I had to refer for this topic. You can have a look at them for further reading and for further understanding. Thank you so much.